Today, Dr. Vineet Malhotra, everybody knows him, such a gentle person. He has done his MS surgery from Nagpur, then MCS urology from Nadia, Gujarat, and he practiced in South Delhi for last more than 20 years. He has been to many top hospitals of South Delhi, and now he has established his own hospital, VNA, that is Vineet and Abhishek Hospital. So we all should support him. I could not do as much as I wish, but I will try. So Dr. Vineet's talk today will be on cancer prostate surgery and what is new in medicine and surgery. I just heard him that he has some unique data as far as radical prostatectomy is concerned for cancer prostate. So I will hand over mic to Dr. Vineet Malhotra. I will introduce Dr. Abhishek later. So Dr. Vineet, you can start.
Thank you so much, sir.
Their clean hospital is in Malhotra, now Jeevan Vihar.
Thank you so much, sir, for your kind introduction. We will quickly actually begin with some comorbidities associated with BPH. We know that unregulated proliferation of the connective tissue, smooth muscle and glandular epithelium of the prostate leads to the benign enlargement of prostate. This will result in compression of the urethra and will result in bladder outlet obstruction. What I want to highlight today before I begin the session on newer medical therapy for cancer prostate is that there are several etiologies which have been associated with BPH: metabolic syndrome, hormonal alterations, inflammation, aging prostate, diabetes being among some of them. The pathophysiology of metabolic syndrome involves insulin resistance with sympathetic nervous system activation, hormonal changes, pelvic atherosclerosis, and inflammation. And it's shown that prevalence of metabolic syndrome with mild roots increases up to 40%, and risk of having metabolic syndrome in men with clinical BPH increases by 37%. So prevalence of metabolic syndrome in Asian men with BPH is very, very high, almost 50% of men. And this results in a transitional zone growth, median annual growth, which is found to be significant, clinically significant. So BPH patients with metabolic syndrome have higher prostate growth rates, larger prostate volumes than those without metabolic syndrome. That's to do with metabolic syndrome. Now what about diabetes? Again, with patients with diabetes, we know they'll have a weak detrusor, impaired detrusor muscle, lower maximum flow rate, increased post-void residue, and therefore increased fluids. The incidence is twice as much as those without diabetes. And there is an incidence of pre-diabetes also associated with BPH, and the studies show that the prostate volume was positively associated with intraprostatic levels of the marker for BPH, the serum PSA and the waist circumference, which was significant, again linking diabetes with metabolic syndrome. And there's a hypothesis behind how diabetes may increase. Again, it's similar to how the metabolic syndrome works through insulin resistance, hyperinsulinemia, and hyperglycemia. Again, linked with hypertension. This has shown a 1.5% higher risk of moderate to severe wounds compared with counterparts, larger prostate volume, higher annual prostate growth in men with hypertension. And similarly, patients with CAD showed significantly higher mean serum PSA and a higher prostate volume. What about erectile dysfunction? My favorite topic always. So there's a common pathophysiology of how the erectile dysfunction will be found more in men with BPH. And there is 70% of BPH patients suffer from ED. So that's a huge number of men that have benign prostatic hyperplasia and will suffer from ED. It's the most common cause of roots in men above 50 years of age. And the treatment of BPH may improve sexual function in men with ED may be related to coexistence. Now remember, This is the basis behind us using now tadalafil as a drug of choice in men that have loops with erectile dysfunction. So if you have lower urinary tracts and erectile dysfunction, tadalafil has become a drug of choice for the reason that symptoms of BPH, symptoms of loops may improve in men where you treat the BPH, and the erectile dysfunction symptoms may also improve. So this has been shown in several groups of studies. Tamsulosin has also been shown to improve both symptoms of BPH and erectile dysfunction. So the IPSS, IIEF, that's the International Index of Erectile Function, and the erectile function score, all of these have shown an improvement with the use of tamsulosin. So 75% of patients had an increase in their erectile score, 83% had an increase in their total IIEF score, and 25% regained a normal score. Now we'll come to the management of non-gastric advanced recurrent or metastatic prostate cancer, and we'll talk about the ASCO guidelines. Essentially, when we look at medical therapy, now when patients come to you for treatment of cancer prostate, they're looking at several things. The first thing that a patient is looking at is, am I going to get curative treatment or am I going to get palliative treatment? Remember, when patients come to you with the diagnosis of cancer prostate, if localized, the only curative treatment options are two. You can have radical surgery or you can have radical radiotherapy. All other options are palliative. So as soon as you offer hormonal therapy, we are coming to palliative therapy, which is why I mentioned whether it's castrate or non-castrate resistance. The terms that we use are hormone responsive or hormone refractory, which means they respond to hormonal ablation or they do not respond to hormonal ablation, and all the treatment is based on this, which means you have this mode of action, which means the LHRH or the luteinizing hormone release hormone reduces androgen production by the testicles by a negative feedback mechanism, blocking the action of androgen receptors through the body and blocking androgen production throughout the body. So that's the mechanism of how LHRH agonists will act. So when do we use the hormone therapy? We use it for early stage prostate cancer, short course therapy if the patients are undergoing, especially with radiotherapy. We don't prefer it with surgery. The reason we don't prefer to give any kind of hormonal therapy before surgery is that it causes a contraction of the prostate, which also makes you lose the surgical planes and margins. So we are not too happy when a dose of hormone therapy has been given before surgery. But before radiotherapy, this is fine because the margins in radiotherapy are a little bit more blurred than they are in surgery. So it's okay to give a short course of hormonal therapy before that. You give it for locally advanced prostate cancer, longer courses up to 3 years before radical radiotherapy. And again, when you're looking at more advanced or metastatic cancer prostate, then it's going to be lifelong therapy. And in a bit we'll talk about how this lifelong therapy can be. Is it continuous, is it intermittent, is it early or delayed? Symptomatic and or biochemical progression in men with prostate cancer. So there are two kinds of treatments that are offered. If you have low-grade disease, we call it Gleason 6, 3+3. That's the lowest grade of disease that you can get. You can be put on what's called surveillance or watchful waiting. And in that case, again, if there is biochemical progression, which means that the PSA rises, you may give hormone therapy. That's one option. You may also offer surgery or radiotherapy in such cases. Or if someone has received some kind of surgery and then has had a biochemical progression, surgery, radiotherapy, then biochemical progression, you may offer adjuvant hormonal therapy. Now the treatment options in terms of hormonal therapy are androgen deprivation therapy in the form of orchiectomy. That's been the commonest form. Remove the testicles, the source of 95% of all testosterone is produced in the testes. You've removed that, that's androgen deprivation. or you use anti-androgen blockers, LHRH, injectables and agonists. Anti-androgens such as bicalutamide, flutamide, they've been used for ages. Now there are newer agents, we'll just talk about them shortly. So these are the newer agents. They have a stronger bond to the androgen receptor. They block its receptors. They prevent any external cell stimulation. Enzalutamide is one of them. Apalutamide is one of them. Daralutamide is one of them. So these are the newer hormonal therapies. In fact, you may listen to or hear about them in the coming days because they are being marketed aggressively, and they are used now in the treatment of cancer prostate, which may be castrate responsive or resistant, hormone responsive or resistant. So daralutamide can be given to patients that have non-metastatic castrate resistant disease with biochemical relapse. So what are we going to look at? We'll just look at some of the questions. Now, what is the initial treatment that you will give for metastatic non-castrate prostate cancer? Will you use monotherapy or will you use combination therapy? Will you give early treatment or will you wait and give treatment? And will you give continuous treatment or can you give intermittent treatment? These are things that are asked by patients on a very common basis. You know, this is long-term, lifelong therapy. And a lot of patients are told about intermittent therapy, which means you give medicine, the PSA falls to almost undetectable levels. Can I stop it now for some time? Can I restart it later? There is data regarding this. Can you use what is called intermittent androgen deprivation therapy? So, little bit so that you can answer your patient about it. So, what is the standard initial treatment that you will use for prostate cancer? So again, there are two groups here. Do you have metastatic disease which is high volume, or do you have low volume metastatic or non-metastatic disease? If you have non-metastatic disease, you will use oral medication, and the oral medications usually will include abiraterone. Abiraterone is the commonest drug that is used. Otherwise, you will use enzalutamide. Apalutamide is a common drug, is a newer drug that's coming now. Or if there is metastatic disease which is high volume, then you will use chemotherapy. Remember, in cancer prostate, chemotherapy is not used because of the high incidence of adverse effects and lower response with chemotherapy. Docetaxel is the only favored drug, but also that is used far less commonly. We use it with prednisolone in combination, but extremely rare to use chemotherapy for cancer prostate until unless it's high volume metastatic disease. So the recommendations are for men with metastatic non-castrate prostate. In fact, there are trials. There is this trial that's called the Charter trial, and this says that as defined for Charter who are candidates for treatment with chemotherapy, docetaxel is added to the androgen deprivation. What do you mean by androgen deprivation? You mean the removal of the testicular source, which means either you give a LHRH agonist, you give an injection like Lupride or something, LHRH agonist, or you do orchiectomy. So ADT, androgen deprivation therapy, plus you use docetaxel. This is with high volume disease. If you have low volume disease, docetaxel should not be offered. Now for men with high risk de novo metastatic non-castrate prostate, abiraterone is the drug of choice here, and you may offer abiraterone with androgen deprivation therapy in these patients. So the dose here is 1 gram of abiraterone with prednisolone 5 milligram once daily until unless it outgrows this. So remember, all hormone therapy is palliative, and the cancer will always outgrow the disease and you will always move. So we say first line hormone therapy, second line hormone therapy, third line hormone therapy, which means that you will progressively over a period of time move from one type of hormone therapy to a more advanced or more higher kind of hormone therapy, because the disease will progress, because this is only palliative. If you are using enzalutamide, this is used in a 160 milligram. It actually comes in 40 milligrams tablets, and you use it as 160 milligrams per day. And you may use the newer agents also, such as apalutamide in men with metastatic non-cancerous cancer, especially those with de novo metastatic disease, or those who have received prior therapy, such as I mentioned, patients that have had previous surgery or radical radiotherapy. So that was the first question. What is the initial treatment that you will use? The second question was, do you use combination therapies or do you use monotherapies? And this, unfortunately, is a question that's not been answered. So most monotherapies are as acceptable as combination therapies. There's no advantage to a combination therapy versus a monotherapy. So you may go ahead and use single drugs, single therapy for patients that have metastatic or non-metastatic, especially for those with non-metastatic disease. Those that may have progressed after radical surgery or radical radiotherapy. Now, do you give immediate androgen deprivation therapy or do you give it deferred in men with non-gastric, locally advanced, non-metastatic disease? Again, this question is, will you treat them with immediately depriving the androgen supply here, or can you defer it? And again, this is a variable reply, though there is more evidence towards early immediate androgen deprivation therapy in men who initially present with non-gastric, locally advanced, non-metastatic disease, which means that if someone has presented with this, you may offer a early injectable LHRH agonist or orchiectomy in such a patient. And you must discuss, now all of these cases, because the evidence is not so strong, you must discuss all of the options, the advantages. Now ADT is not something that comes without side effects. Remember, when you take away the testosterone, the muscle mass will go, the bone strength will go, the patient will lose libido, the patient will have erectile dysfunction probably because of the age that he's got this testosterone deficiency in. So this is a patient that will end up with depression, with mood loss, he may have lost his testicular function, he's going to have bone strength loss, muscle mass loss. It's a patient who's going to have a lot of side effects, hot flushes probably. So if you are going to give this patient so many adverse effects, you better counsel him about this before you start this kind of treatment. And deferred treatment, especially in patients that don't want this, there will be men that will tell you, we do not want these kind of side effects, will ask for deferred treatment. Finally, the question, will you give continuous androgen deprivation therapy or intermittent androgen deprivation therapy? And intermittent androgen, they've actually found no difference between these. Intermittent androgen therapy has found to be equal in respect to the evidence for continuous androgen deprivation therapy. And so you may offer both of these options depending on what the baseline PSA has been achieved after proper patient counseling. Now, coming to one of the other things that we spoke about was radical surgery. The options for radical surgery, when you talk about radical prostatectomy, is robotic, laparoscopic and open radical prostatectomy. And you'll hear this, it's like the new candy in town. You've got a new candy in town and that's become the flavor of the month. And robotic seems to be the flavor of the month. But remember, the tool is only as good as the person sitting behind the tool. And if you do not have someone that's an expert user of the tool, the outcomes will be very different. So the next time you find that you have sent a patient for robotic radical prostatectomy, please ask these questions. Ask him whether he got completely cured from the disease. Ask him, and when I say completely cured, it means the PSA should be undetectable, less than 0.02. Your lab should not be able to identify any detectable levels of PSA after the surgery. What risk of procedure did he entail? What was the blood loss? Did he receive any blood transfusion? What was the post-op recovery time? What was the catheter time for the patient? Remember, this is very important. We don't think about catheter times, but the recovery in terms of continence depends on how long the catheter has stayed inside. The sphincter responds better if the catheter has been removed early. So the continence rates, the post-operative sexual function, we may or may not talk about it, but again it's an important function when you've been told you've undergone a nerve sparing procedure. And the long-term disease-free status, okay, you may be PSA free in the first 3 months. How much are you after 1 year? What is your PSA status after 2 years? Are you still disease-free? Have you been given adjuvant treatment? Now, a lot of times, what will happen is after a procedure that's been done, where the margins are questionable, you'll receive a dose of hormonal therapy immediately or radiotherapy. Now, that's not a treatment which was ideal. You got adjuvant palliative treatment along with the treatment, and that's not ideal. So, these questions are to be understood. And I can tell you at VNA things have been different. Now we've done a lot of laparoscopic radical prostatectomies. In fact, we've operated a doctor's husband. We have till date complete clearance in all patients. We remove the catheter on the 5th day, which is practically done in less than 2% of centers in the country, irrespective of whether you do a robotic surgery, laparoscopic surgery or open surgery. Less than 2% of centers in this country remove the catheter on the 5th day. We remove the catheter on the 5th day for the patient. We're in fact doing another one after 2 weeks, and you're welcome to come in and see the records for the patient, but that's how we do it. The patient is continent by 2 weeks. Again, this is something that I can tell you by sure that there's less than 2% of centers in the country which will guarantee continence within 2 weeks after surgery. We are able to we rarely give blood transfusion to any of our patients. Our average blood loss is less than 100 ml in patients that undergo a laparoscopic procedure. This is practically not comparable with most centers in the country, whether they are undergoing a robotic surgery, laparoscopic surgery or an open surgery. We are able to do nerve sparing procedures in patients that require a nerve sparing procedure or okay to undergo nerve sparing, which means that they don't have a widely spread disease. And you're all aware we are able to treat sexual dysfunction. We are in fact one of the premier centers in the country to treat sexual dysfunction after radical prostatectomy in all of these patients. And we've rarely used, so of these patients, none of them is on adjuvant therapy, which means we are not using either radiotherapy or hormone therapy in any of these patients, and they all have undetectable levels of PSA post-surgery. Which means our patient selection is also appropriate. We are not doing radical prostatectomy in patients that do not warrant a radical prostatectomy. But I would welcome you to come and look at our data for laparoscopic radical prostatectomy. Thank you so much for your kind attention.
Thank you, Dr. Vineet. We'll have questions at the end of both the lectures. So now I invite Dr. Abhishek Mishra, the another partner in VNA hospital. He is also a good friend. He is a reputed orthopedic surgeon and he is also operating in the hospital where I am operating Apollo Spectra besides his own hospital. And he graduate and postgraduate from Maulana Azad Medical College. And then he has also done MCH from UK. So he is a big name in orthopedics now in South Delhi. So Dr. Abhishek, you can start here.
गिलास नहीं रखे होंगे ये करके कोई बात नहीं ऊपर से ले ले सबके फेस ले ले बस टेबल को हटा दे पता नहीं चलेगा टेबल को हटा के ऊपर से ले ले टेबल
Good evening, everyone. being in front of this group is always like homecoming. It's like most familiar and most comfortable gathering for me. So today we are going to talk about arthroscopic surgeries, and the entire idea of presenting this is to make you aware. Like I know as general physicians, as primary doctors, the first person, the first healer, the first doctor whom the patient comes across to with his or her problems about knee and shoulder are you actually. And
excuse me, please maintain silence in the back.
in last 30-40 years, like arthroscopy has been there for last 60-70 years, but in last 30-40 years it has increased, and in last 5 to 10 years it has increased, it has improved dramatically, tremendously and exponentially. The indications of procedures, arthroscopic procedures, the surgeries which we can do arthroscopically, especially for the knee and shoulder, it has become manifold now. Like I would tell you, say around 10 years ago in India, there are hardly 1 or 2 surgeries for which arthroscopy was considered. One was like meniscectomy, that was partial meniscectomy. Another was synovectomy or cerebral biopsy. Only for these 2 surgeries, arthroscopy was considered. But now the list has extended from 2 to almost 20. So, basically, so just I begin with, basically we are going to talk about, arthroscopy can be done for many joints, like elbow, ankle, but most commonly we perform arthroscopy for knee and shoulder. And I'm going to talk very briefly about indications of arthroscopy for knee and shoulder. So as I told you earlier, for every meniscal tear, I'm talking about 15-20 years ago, to remove the meniscus. Let me tell you that removal of meniscus was one option which was very prevalent at some point of time. But nowadays, last 3-4 years, meniscectomy or meniscus removal is supposed to be very obsolete or kind of redundant procedure. Nowadays, we try to repair each and every meniscus tear, and we try to salvage the meniscus, howsoever bad the tear is. So now the trend, like last 10 years, the trend, especially last 5 years, the trend is from meniscectomy to meniscal repair. So these are the different kinds of tear in the meniscus, and depending on the tear is the recovery. So sorry. Meniscus, actually I'll tell you something very interesting. Like almost 60-70 years ago, meniscus was supposed to be a vestigial structure, a useless structure. But now everybody knows that meniscus is a very important structure in the knee. It provides the congruency of articulation between the tibiofemoral joint. It provides lubrication to the knee. It provides nutrition to the knee. It is a stabilizing force of the knee. So removal of the meniscus is not advisable at all, especially in younger individuals. And these are the different types of tears, and depending on the tear is the recovery or the treatment. So one thing which is very important is when we talk about so this is basically a depiction of a meniscal tear, and this is an important slide. So basically these are the blood supply zones of meniscus, and it's very easy to understand. Basically the blood supply to meniscus, you are looking at the tibia. This is the end-on view of the tibia, top view of the tibia. This is the anterior part, like tibial tuberosity. This is the posterior part. This is the medial meniscus, which is half circle shape. and this lateral meniscus which is almost complete circle shape. And lateral meniscus, it occupies a greater surface area. Usually medial meniscus is more commonly torn as compared to lateral meniscus. The reason why medial meniscus is more commonly torn is medial meniscus is less mobile, like it is more fixed, and that's why it can get a tear. So on MRI, how do we decide that which meniscal tear has got a better prognosis, after repair or without repair? Basically the tears which are in the outer part, the peripheral part, basically the different parts of meniscus are divided into different zones. This is the red zone, this is the white zone. So the outer the tear, the more are the chances of healing. Why? Because the blood supply is coming from the outer side. So if there is a tear here or tear here, it will repair nicely, it will heal nicely. Like if it is a simple tear, then it can repair even without surgery. If it's a complex tear, then you have to operate and the prognosis is better. But suppose a tear is here or tear is here, the chances of recovery are less even after surgery. Why? Because the blood supply is inherently not so good. So basically it's about the location of the tear, which is very important in meniscus when we talk about repair surgeries. So basically this is a animation of how meniscal repair are done. Nowadays every company has come up with their own devices, and all this procedure is done like arthroscopically. So this is a special device. It comes by the name of Sequent or Fast Fix. They are different names. And suppose this is a tear. This is a very simple like horizontal tear in the posterior part of the medial meniscus, and this is the behind. So you have put a knot here, and through that device, arthroscopically, this is the thing to place the suture. So this is another knot, and you can see you have, as you pull it, the torn ends they come together. As you will pull it, the torn ends they will come together. So you see we are pulling it, the torn ends will come together, and gradually with time and rest is going to heal. So basically this is a very simple, just like we do a laceration, the stitching of the laceration, same thing is being done with arthroscope for meniscal tears. So the idea is saving a meniscus is very important. So like meniscus surgery, partial meniscectomy, meniscus repair, meniscus transplant. Meniscus transplant is actually a theoretical thing which is being done in the West, but not very popular, not very common. So the one thing which we have to focus on is meniscus repair. Now technicalities I think is in very much detail, so I'll just kind of fast forward it, how the OT setup and everything. So there are some videos from the operation theatre, and that will give us a rough idea about how this arthroscopic procedure is done. Basically we create portals, we go inside the joint, so we remove the so basically this is a torn meniscus, we debride. So small parts of the meniscus which is not amenable to repair, which we can't repair, we just remove them. We will just remove those parts, and the main tear is repaired. And this is hypertrophied synovial and fat pyramidal. So to make to visualize the joint in a better way, we clean up this entire area. So actually this is a very long video. I'll just show you another video which is short and easier to understand. So you can see that these are the sutures which have been used which have been put arthroscopically, and we tie them up, we cut the knots, we kind of fix the sutures, and we bring the torn ends come together so that they heal over a period of time after rest. So this is another, sorry, I just want to show you something. So indications of, when we talk about indications of knee arthroscopy, basically earlier knee arthroscopy was done just for removal of meniscus, that is meniscectomy. Nowadays there is a long list Like we do anterior cruciate ligament reconstruction arthroscopically, we do a posterior cruciate ligament reconstruction arthroscopically, we do a medial meniscus repair with arthroscope, we do a lateral meniscus repair with arthroscope, we do cartilage procedures like OAPS or cartilage implantation with arthroscope, we do synovectomy with arthroscope, we release stiff knee by arthroscope. There is something called adenolysis and manipulation anesthesia. So the list is already big, like from 2 procedures 10 years ago to almost 15-20 procedures now, and the list is ever increasing. So many procedures are being dealt with arthroscopically. Why I stopped here is I just wanted to show you a cartilage defect. Let me just go back a little bit, and probably you can see here. This is just the meniscus being fixed. This is the meniscus being repaired surgically. And sutures being passed from the posterior horn, from the root. This is the root of the meniscus. This is the root of the meniscus, this is the posterior horn. Already some repair has been done, the repair is being finished. I just wanted to show you the cartilage defect, how the cartilage defect looks like. So, this is the upper part, this is the femoral condyle. And you can see that this is not very smooth. Like it has craters, it has drops. A normal femoral condyle, which has got a pristine, which has got a nice cartilage, it looks very smooth. But here you can see there is a defect. So there is a cartilage defect. And some cartilage defects can also be dealt with. Actually this video is more about meniscus repair. That's why cartilage defect is not emphasized. I just wanted to show you how the cartilage defect looks like. So basically you pass sutures here and there and you try to bring the torrents together and you try to keep them stable for some time. Everything is being done arthroscopically. And I will tell you, like 90% of the repairs, they are successful, they heal over a period of time. Divided your patient selection is right, provided the location of the tear is okay. It's not in the very inner zone. So exactly this is what I wanted to show you. So there are many procedures which can be done for cartilage repair or healing of the cartilage. This so you can see this. This is a defect in the femoral condyle. See, this I wanted to show you. And so this is almost the normal cartilage, and this is the big defect in the femoral condyle. This is the cartilage defect, which can be dealt with by other procedures like OATS or cartilage transplant. So another procedure which is very commonly done in knee arthroscopy is arthroscopic ACL and PCL reconstruction, anterior cruciate ligament and posterior cruciate ligament reconstruction. Here we just take a graft from hamstrings or patellar tendon bone, one of the two. Right, this is a torn meniscus. This is the graft being harvested. So these days, like the most common choice, most popular choice or most accepted choice for graft is the hamstring graft. We take gracilis and semitendinosus with very small incision, and this is how the graft is harvested. So you can see these two tendons being harvested, and there is a device, it's called tendon passer or tendon stripper. So you will just see the tendon stripper is used to smoothly take out the grafts, and these grafts are then implanted onto the site where the original ACL was. So this is the tendon stripper. So this is the first tendon being stripped or taken out, and now the second tendon will be taken out. And then the graft is prepared on something called graft station. So there is a specific thickness of the graft. The normal thickness of ACL, or native ACL, is approximately 11 millimeters. The graft thickness which we usually get is 8. This is how the graft, the tendon is being prepared. So the flesh muscle is removed, the graft is prepared. To get the adequate thickness, the graft is folded onto itself. You can fold it from 2 to 6 times, depending on what thickness you want. So hamstring is one of the options from where you can take a graft. Other place from where you can take a graft is patellar tendon bone graft, PTB. Earlier this PTB graft, patellar tendon bone graft, was very popular, very common, but there have been instances of anterior knee pain and increased osteoarthritis with patellar tendon bone graft. So this is how you see this is the tunnel in the femur, and this is the endo button being passed. So we tie on one end of the graft, we put endo button, and the other end of the graft we fix either with bio screw or with endo button. This is surgeon's preference. Like different people, they follow different methods, but the most commonly accepted or most commonly done implant fixation these days is endo button on femoral side. This is the femoral tunnel. Probably you can appreciate it. This is the femoral tunnel from which the graft is being passed. And on the other side, you will have the tibial fixation. Tibial fixation most commonly is done with bio screws. So this is the graft which is now going inside the femoral tunnel. This is the femoral tunnel. So I was telling you other option for getting graft is peroneal graft. So here you can see that this is the ankle. You are taking out peroneus longus tendon to use as a graft. And the advantage of peroneal graft is it is thicker, it is stronger. So again the same procedure. The peroneus longus has been isolated, and we use a tendon stripper to take out the peroneus longus. The remaining part of the peroneus longus, the base of the peroneus longus, we tie with peroneus brevis so that the eversion is not affected in long run. Eversion of the foot is not affected in long run. So all these are all these surgeries. So this is how the site of harvesting of hamstring graft. I'll just fast forward it. These are all clips from surgeries done at our hospital. Vienna Hospital, in a very short span of almost 2 years, we have done more than I would say more than 200 joint replacements and more than I would say 100 arthroscopic procedures there. And I am very proud to say that we have been lucky enough to operate on patients from at least 15 to 20 nationalities in our not so big setup. So supposedly it's a very not so big setup like corporate hospitals, but still we have been attracting patients from all parts of the world. It has west, east, north, south, and all parts of India also. And we have done multiple types of orthopedic procedures, including arthroscopy, joint replacements. So very quickly again, I'll just skim through it. So there are various techniques. Now, just a basic. Now, we spoke about this knee arthroscopy very briefly. I'll just go through shoulder arthroscopy because we are running short of time also. And very important thing is to know the indications of shoulder arthroscopy. Here the graft, here the final step of the surgery when the tibial part of the graft is being fixed with the bone. So about shoulder arthroscopy, again shoulder arthroscopy is a very rapidly developing procedure these days, and these are the indications for So this is the position in shoulder arthroscopy. So this is how we keep the patient when we are doing shoulder arthroscopy. These are the various devices in shoulder arthroscopy. Now again, this is a very long presentation, but I'll just briefly explain to you. Very important thing is to understand the indications for shoulder arthroscopy. In present day, what are the indications of shoulder arthroscopy? Shoulder arthroscopy we are doing most commonly for rotator cuff tears. We all know that rotator cuff is a very important structure, and a tear of rotator cuff can impinge the damage the movements, restrict the movements around the shoulder joint, can make the shoulder joint very painful, and it can lead to very early osteoarthritis of the shoulder joint, necessitating a shoulder replacement. So for supraspinatus repair or rotator cuff repair, we are doing shoulder arthroscopy. Another condition or another indication for shoulder arthroscopy these days, very common, is labral repair or treatment of recurrent shoulder dislocation, which is very common in younger individuals and sports individuals. Labral repair or capsular repair. Other indication for shoulder arthroscopy is removal of loose bodies. Another indication of shoulder arthroscopy is treating osteoarthritis also, like we can do microfractures and other things which we can do with shoulder arthroscopy. So what I'm trying to say is the scope of shoulder arthroscopy is increasing every day. So I'll just again, this is an animation of how a Bankart's repair. This is a treatment for recurrent dislocation of shoulder. And what happens in recurrent dislocation? In recurrent dislocation, you can see there has been a tear. There has been a tear between this is the labrum, this is the cartilage. So between the articular surface and the labrum, there has been a tear. So we create portals, different portals during surgery. There is one working portal, there is one visualizing portal, and there are accessory portals. Accessory portals can be many. And these are all devices, special devices to repair this. So this device, this is called suture anchor. This suture anchor is going onto the bone, and this repair will again be fixed with the help of suture anchors. So we are putting some stitches in the labrum, and we will be tying both this how it looks from outside. We will be tying both these together so that the torn ends are approximated. So we just pass this suture from this loop and we will tie them together. So one of the sutures is brought close to each other, and you see this is the defect. This is the defect from where the head of humerus tends to come out. Mostly it's in the anterior-inferior part of the labrum. So as we pull it and tie a knot, the torn ends will come together. And we use suture anchors. We use up to 4 or 5 suture anchors, depending. Sometimes 6 or 7 suture anchors can also be utilized. It depends on the size of the lesion, how big the lesion is. So this is a cannula which helps to. Now this is this device is called a bird's beak. Now there's so many devices, specialized devices for different functions for doing shoulder arthroscopy. So this is just a brief representation of how a Bankart's repair or a labral repair is done to treat this condition called recurrent dislocation of shoulder. And you will see that as we start like tying the defect, after some time, once you pass 3 or 4 suture anchors, the gap will be closed, the defect will be closed. So similarly, we pass like a couple of, here we have passed 4 suture anchors, and you can see the shoulder joint has again become strong and the defect is filled. I think we are running short of time. I'll just so again this is a video from our so I'll just I think we have already, I think this should be. We can deal with the rest in question answer session. We have time. Okay, so 2-3 minutes. So basically what very interesting thing is history of arthroscopy. Like our hospital, we are doing all surgical procedures, but the main pillars in our hospital are urology and orthopedics, like arthroscopy and joint replacement, all those things. And when I was reading about history of arthroscopy, I was very fascinated by the fact that the first arthroscope was actually not an arthroscope, it was a cystoscope. So there was a Japanese surgeon who wanted to look inside knee, like cavity, like knee. And he was supposed to be one of the fathers of arthroscopy. And he used a cystoscope. And gradually, like cystoscopes, thoracoscopes, and gradually from cystoscopes and thoracoscopes, we had arthroscopes. And in our hospital, in VNA hospital, we have one of the most advanced arthroscopy system. It's by Karl Storz, and we are doing at very competitive prices, and we are doing to the immense satisfaction of the patients. So I think I'll finish with my talk here, and whatever questions are there on arthroscopy, I am ready to answer those. Thank you very much. Thanks.
Thank you, Dr. Abhishek, for showing us so many arthroscopic surgery. Okay, so we'll take question first for our first speaker, Dr. Vineet. Dr. Abhishek can join later.
Dr. Poddar has told me that we would request all of you to please sit here. What we see is that there is an exodus after the talk, and it is not a very good reflection on our forum. Whoever is going to leave for dinner is only requested to ask one question. That's all. Ask your question, leave for dinner. It's a simple deal. Dr. Saxena sir. Dr. Saxena sir is not intending to leave for dinner. He is still intending to ask a question.
Okay, yes, you can.
So what is your advice for a CA prostate patient, 80 years plus with advanced metastasis in the brain, 80 years age?
So, if I were to be told by God that I am going to give you cancer, please select your cancer. I would select cancer prostate. It's the slowest growing cancer in the body. And at 80, I would only look at palliative therapy for symptoms and give organ therapy based on this. Now, I would not use chemotherapy. Now, I mentioned high volume disease where docetaxel is used, but docetaxel comes with severe adverse effects also in cases. So with 80 plus and metastatic disease, I would look at other palliative hormone therapy and not look at any other options. So, so when we say hormonal therapy, it could be monotherapy or combination therapy. Again, we've discussed that you can use either. My preference is to do either orchiectomy or to give LHR antagonist depending on how the patient is. Remember, these patients, you tell a man you are going to remove his testicle, emasculate him, it has a profound effect on his mental status. It's not easy to emasculate someone. So you have a simpler option. You just give LHR antagonist and it works in the same way. These days, I don't remember when I have done an orchiectomy in the last 10 years. Because I counsel the patients and I offer them LHR antagonists. Now we have therapies which are available once in 6 months. You just need to give the injection once in 6 months. It's far less depressing for the patient. You know, losing the testicle is major trauma. So I would suggest give LHR antagonists.
Orchidectomy is out after so many anti-androgens are available.
नहीं सर, ऐसे आउट नहीं कर सकते। सरकारी में हम भी ऑर्टिकली करते थे। तो I think you have to be prudent. You have to offer what is acceptable to the patient.
I have to compare.
Doctor, you asked about the role of tadalafil in BPH. So can you use tadalafil without alpha blocker, or always it should be with alpha blocker?
No, in most cases I use it without alpha blocker, which means it's tadalafil alone for treating BPH with loops, not tadalafil with alpha blocker.
So what will be the main action of tadalafil in BPH? Because we know tadalafil is basically improving erectile dysfunction. In BPH, what will be the main mechanism?
It has a alpha blocking effect at the bladder neck, and it causes relaxation at the bladder neck, and so it has an independent effect on the bladder neck, apart from the fact that it is going to have effect on PD5 also.
So it can be used for BPH or loops without alpha blocker.
Absolutely.
So one comment on your results of radical prostatectomy laparoscopic. So you have shown wonderful results. But whether it is reproducible by the other laparoscopic urologists, because when we compare with robotic, your results were as good as robotic radical prostatectomy.
No sir, my results are superior to robotic in most hands. It's very important to understand that in this eagerness to adopt a new technology, a lot of people who are less trained. Now, robotic surgery is a little bit like open surgery, which means you don't really need the skills that you require for laparoscopy. Laparoscopy requires really intense training and skills. So the comparison between robotic and laparoscopy is not fair, because robotic compares with open surgery, not with laparoscopy. So for laparoscopy, you need to be better trained. For robotic surgery, you can be less trained and you can still get away with robotic surgery.
That was my question. So laparoscopic radical prostatectomy, not all laparoscopic surgeon can do it, but radical prostatectomy, that's what I was about. Radical is easier to do, but laparoscopy you have to get better.
Both of you are doing wonderful job at VNA. I have a simple question to Dr. Abhishek.
First, Dr. Vineet.
He said meniscus are very important nowadays. If you remove, what precaution we can take in future?
Sorry, sir.
If you remove meniscus, what precaution
So
we
it
can
depends on so many things.
take?
What is the meniscus was removed, how much of the meniscus was removed, and what is the activity level after meniscus. So these are very important things which we need to consider. But generally, you see, if we do it at a young age, the slow death of the knee is guaranteed. So, sir, आपकी शायद
Playing like badminton,
you should not be doing it.
football and cricket.
But then again, sir, I tell you, अगर थोड़ा बहुत निकाला है, like inner part, हल्का सा tear है, थोड़ा बहुत निकाला है, it doesn't make much of a difference. But it's significant. सबटोटल मैनिसेक्टमी की हुई है। पुराने जमाने में 15-20 साल पहले सबटोटल मैनिसेक्टमी बहुत कॉमन था। थोड़ा सा मीडिया होता था, पूरा मस्त होकर निकालते थे। So after that, ये बैडमिंटन और ये सॉकर और ये is not advised. Especially if you are paid. If you are lucky, you will get away with it for 20, 30, 40 years. If you are not so lucky, 15, 20 years. Like we see many patients. कई पेशेंट ऐसे आते हैं जिनका एक घुटना ना एक्सरे कराते हैं, एक ही में पेन होता है, एक घुटना एकदम प्रिस्टीन होता है, बढ़िया एकदम चिकना मस्त दिख रहा होता है, और दूसरा नी जो है ऐसा दिख रहा होता है कि लाइक 45 साल का आदमी, बट नी इज लुक लाइक 75 or 80 years old, totally degenerated, especially one compartment. और उनको बाद में पता लगता है, पूछो तो या तो नी की सर्जरी हो रखी होती है पहले कभी, या फिर नी की कभी इंजरी हो रखी होती है, इसमें इसका क्या होता है जो कभी ट्रीट ही नहीं होता है।
Dr. Kaji has a question.
Dr. Vineet, instead of CA prostate surgery has been done, how long normally the incontinence already remain?
Sorry sir, I didn't get your question.
How long after CA prostate the surgery has been done, incontinence of urine remains for how long? How long he has to use your diaper and all?
Sir, I put that data up. Now it depends a lot on how the surgery is done and what result you expect, which means when did we remove the catheter? We remove the catheter on the 5th day. Most centers remove the catheter at 3 weeks. We have patients that are continent at 2 weeks. Most patients look at partial continence by 3 months to 1 year. I'll just give one example. I'm not naming any doctors or anything here, but there was a patient that underwent a biopsy by me, was found to have a operable cancer prostate, underwent a robotic radical prostatectomy at a hospital which is right next door, so you should be able to understand this is the big hospital right next door to us, and developed bladder neck obstruction, is on permanent suprapubic catheter after that. He has been operated at the biggest corporate hospital right next to us, is on permanent suprapubic catheter after that. He is willing to accept that because it's a big hospital, he cannot complain to anyone. But we do not have any such patient. We have continent patients voiding urine. So you have to be, which is what I'm saying, it's the simple fact that it is not about whether you are doing open surgery. In fact, there's a surgeon called Patrick Walsh in the US who does fantastic surgeries by open surgery and gives the same results as laparoscopic and open robotic radical prostatectomy. It's about the procedure.
Dr. Sumit Sharma.
Dr. Mishra, fantastic videos. Very nice videos we saw. So I just need to know the actually lifespan of the ACL graft. Please let me know what happens, how you do a follow-up. Let's say 5 years, 10 years down the line after surgery.
So there is a ACL, when we do ACL reconstruction.
आवाज साउंड
Sorry. So talk about ACL reconstruction, it depends, there are 2 factors which define what kind of graft was used, what was the thickness of the graft, what was the strength of the graft preoperatively. So they said, I told you like the ideal thickness, the natural thickness of ACL is approximately 10 to 12 millimeters. An uninjured ACL, like normal ACL. The grafts which we get, especially Indian patients, it's hardly even more than 8 to 9 millimeters. When 8 millimeter graft में मिल जाता है, we consider ourselves lucky. हमने ग्राफ्ट लगा दिया, एक नॉर्मल थिकनेस का ग्राफ्ट है और पेशेंट की एक्टिविटी लेवल क्या है, अगर वो स्पोर्ट्स वाला है और वो हाई इम्पैक्ट स्पोर्ट्स में दोबारा जा रहा है, उसको ट्विस्टिंग इंजरी होने के चांसेस ज़्यादा है, तो उसका ग्राफ्ट सर्वाइवल थोड़ा डाउटफुल रहेगा. डिपेंड करता है एक्टिविटी लेवल है. स्पोर्ट्स देखिए अगर फुटबॉलर है और प्रोफेशनल फुटबॉलर है और वो अपना फुटबॉल समझिए कि उसको 20 साल में से रिकंस्ट्रक्शन हुआ 20 की में, सो और वो दोबारा वैसे ही प्रोफेशनल लेवल में फुटबॉल में चला गया. So there is a high probability that he might get a rare tear or loosening of the graft, or the graft will become slack in another 5-7 years.
So he has to leave his context.
No, it's not like this. It's not like this. He has to motivate. So basically, जब हम कर रहे होते हैं सर्जरी, तो हम पेशेंट का ऑक्यूपेशन या उसकी एक्सपेक्टेशन क्या है, उसके हिसाब से हम ग्राफ्ट लेते हैं, उसके हिसाब से पेशेंट को 10 मिनट. सो अगर हमारा ग्राफ्ट पतला होता है, स्पोर्ट्समैन है, हम चाहते हैं कि वो इमीडिएटली स्पोर्ट्स में चला जाए और आगे भी दिक्कत ना हो, तो हम ग्राफ्ट के साथ ना कुछ एडजुवेंट यूज करते हैं, फाइबर टेप डाल देते हैं या बायो फिल्म, ये बायो ये आता है. There is a graft like structure which is not exactly synthetic, और वो बायो ग्राफ्ट टाइप का होता है, वो एडजुवेंट होता है, वो ग्राफ्ट की स्ट्रेंथ बढ़ाता है.
So these adjuvants have been added in the recent past, last 5 years or past?
Last 3-4 years.
Okay.
पहले की था, पहले
और अगर कॉन्टेक्ट स्पोर्ट्स नहीं कर रहे हैं, then what happens? अगर स्पोर्ट्स नहीं करना है,
सो
कितने साल है?
स्पोर्ट्स नहीं करा तो जिंदगी भर रहेगा.
Until दोबारा कोई ऐसा एक्सीडेंट हो जाए, रोड ट्रैफिक एक्सीडेंट हो जाए, फिर तो नहीं होता है. अगर नहीं होता तो फिर जिंदगी भर रहेगा.
You don't have to review it.
It becomes no, absolutely not. Until it's present with like some kind of symptoms. So symptoms जैसे कि उसको फिर से अगर वॉबली लगता है कि नहीं is giving way,
ACL को रिविजिट करने की जरूरत नहीं पड़ती है, मेनिस्कस को भी रिविजिट करने की जरूरत नहीं पड़ती है until unless वो symptomatic हो. The only thing which actually needs revisiting is if you have done some kind of cartilage procedure. Then you have to go back after 1 year or 2 years and see how it is helping. But India में ये revisit वाला concept honestly बहुत ज़्यादा prevalent है नहीं, क्योंकि cost associated है patient surgery से करता है. West में it's a protocol. They have to do it. Okay. Thanks.
Dr. Palvi Purwar.
Hi sir, Dr. Abhishek, I have a question, but before that I want to say thank you to Dr. Vineet as a surgeon. I totally understand it's not the approach but the procedure that is more important. So it's not laparoscopy or robotic but the procedure. Dr. Abhishek, I just wanted to ask one question. If there's a meniscal tear in an osteoarthritic knee, would you recommend repairing it?
Obviously repair will not harm, but honestly it won't do any good. Because if there is already osteoarthritis, your meniscus repair is doomed to fail. अब joint space ही कम हो रखा है, तो आपने repair कर भी दिया, तो pressure उस पे loading इतनी हो रही है ना meniscus पे, वो heal करेगा नहीं, और कर भी गया by chance तो करवाने के पास है, इसलिए हमने ऐसे टूट जाएगा. जिनका ऐसा cross osteoarthritis replacement करो meniscal repair का honestly कोई point नहीं. It's just adding one more procedure. एक और प्रोसीजर से आप इंश्योरेंस का पेशेंट है, थोड़ा पैसे कमा दोगे, बाद में टेक केयर करना पड़ेगा.
Dr. Sanjeev Sajjana sir has a question.
Abhishek, quantum malaysiopathy, very common, very commonly.
Very common, especially in young females.
Yeah. About treatment in quantum malaysiopathy.
So actually I'll tell you, 80% of patients they get better just with quadriceps exercises, static quadriceps, and some kind of supplements like collagen and all. Sir?
Supplements help?
Yes, certainly. I will tell you from my 20 years clinical experience. They certainly help. If it is like advanced grade, like grade 3 or something, then probably it won't help.
Surgery?
Then you have to do microfractures or you have to do some kind of cartilage supplementation. But usually कोई कराता नहीं है, कोई करता नहीं है. To be very honest. ऐसे पेशेंट को हम वेट करते हैं, या पेशेंट वेट करता है. बिल्कुल.
Thank you, Dr. Sanjeev. Dr. Lucia sir has a question.
Dr. Vineet, sir, right in the beginning you gave some slides regarding comorbidities with BPH, metabolic syndrome, diabetes, CAD, etc. Now, are they coexistent or cause and effect relationships? Because they are age group dependent. Age group dependent. Because CAD would be present in a fair number in 60 plus age group. BPH would be 60 plus. Metabolic syndrome, diabetes also would be 50 plus. So are they coexistent or do have a cause and effect?
No, so they are not cause and effect. We are not talking about cause and effect here. We are talking about coexistence here. You find BPH and diabetes in those number of patients, and then you find the effects worsening. So in diabetes, particularly, it will be cause and effect in terms of roots. They will not cause BPH per se, but the symptoms will be cause and effect. So if you were to look at BPH, you would have urinary symptoms, urinary tract symptoms, and if you look at a diabetic bladder, you would again look at the same kind of symptoms that you would look at with BPH.
Dr. Bhalat sir has a question. Incidentally, Dr. Bhalat sir is MS surgery. My senior from Samadhan.
Dr. Vineet, I wanted to ask you, the biomarkers are CA prostate. PSA is one, okay, weaker examination will do it. And what other Gleason score and what else?
Sir, PSA by itself actually is not just PSA itself. Total PSA is one. The percentage free PSA is the other. We always say free is good, which means if you have more free PSA, it's a good thing. So the percentage, if you have more of free to total, it's a good thing. Then PSA velocity is one. PSA ratio is another. And then you come to the Gleason and all, those are more histopathological markers rather than biochemical markers. You also have radiological markers such as the MRI findings. Then you have a PIRAG scoring. We have a radiologist here who can talk about PIRAG scoring, which gives us a good idea as to whether we want to do a biopsy in a patient before we even get into Gleason or not. And that gives us a range. So if you were to get a consistently elevated PSA, total PSA in a patient, or a low free percentage PSA in a patient, you would advise what is called a multi-parametric MRI of the prostate, which gives a PIRAG scoring. And if the scoring, again, we find that this has a scoring which is rated from 1 to 5, where we find 3 to be the equivocal rating, which means if it is 1, 2 and 3, we usually will observe the patient follow-up because there may be other causes of elevated PSA such as inflammation, infection and so. And if it is 4 and 5, we will advise a biopsy, which we do as a transrectal ultrasound guided biopsy. These days we have other forms of biopsy. We have fusion biopsies, which can be MRI fusion or ultrasound fusion biopsies. And then understand whether we want to do a biopsy because it is 4, 5 PIRAG scoring, or if it is less than 3 and we want to observe the patient.
How about Gleason score is exact?
So you have Gleason grade and you have Gleason score. Gleason grade is the architecture of the pattern of what is the prostate showing in terms of pathology, and you have 1, 2, 3, 4, 5. And then you have the second most common architecture that you see, which is the score becomes the first most common architecture that you see, and the second most common. When we say architecture, it means most differentiated to the least differentiated pattern. And you have the 1, 2, 3, 4, 5. And when you sum them up is what you get a score, a Gleason sum or a Gleason score. If you have a sum of 6 and below, you call it low grade disease. If you have a sum of 7, which can be 3 plus 4 or 4 plus 3, you call it middle or intermediate disease. And if you have a sum of 8 to 10, you call it high grade disease. So things have changed recently. We used to previously consider 8 to 10 as inoperable. It's not so now. We are still operating even 8, sometimes even 9 now, based on what is the volume, how much of the prostate is affected, what percentage of prostate is affected, is it outside the margins, inside the margins, is SP affected, are there lymph nodes, no. So there are a lot of other parameters that we will look at before we will decide surgery.
Thank you.
I was hoping Saurabh would ask a question. He has obliged our gastro-oncosurgeon.
Amazing talk, sir. My question is a bit relevant also and irrelevant also to Dr. Abhishek. Sir, when people ask me what should be the adequate dose of calcium they should take and when, at what age it should start, what should I answer?
It's for females or it's for males?
Females and males both.
So females around the perimenopausal age, they should give some kind of calcium supplementation. And you know what, this is not written anywhere, but traditionally our teachers and me also, like I also prescribe prescribe calcium in gaps. Like basically I tell them take for 2-3 months and then take a gap of 1 month, 1.5, 2 months and then restart. Why this is because actually in science, like there has been no proven evidence which has shown that calcium has some increased, taking calcium in a prolonged way has some incidence of increased stones, all kind of stones or cardiovascular events. But still, empirically, calcium is prescribed in phases. 2-3 months you take it, 1-2 months you take a break and then you can start. And when you are giving calcium, make sure that you give vitamin D also. If possible, vitamin K.
In males?
Yes. In males, usually we don't prescribe it until the patient has some symptoms related to fatigue or weakness. and that too in males after 60-70 years of age. But I'll tell you a very interesting story, interesting thing, probably you would already know about it. People who are lean and thin, they are more prone to get osteoporosis. And especially as the incidence of DEXA scan, as the number of DEXA scans is increasing, of late, in the last 4-5 years, I've been seeing many males in 40s and 50s who have very severe osteoporosis. And how they detect it, they have no symptoms. They just, sometimes DEXA scan is a part of health checkup. But it's one of the options in health checkup. And by chance, they choose that DEXA scan as that test. And sometimes they come with the scores which are like super surprising. -3.5, -4, like this. But they are generally very lean males, very lean and thin, small, petite males.
My question to Dr. Vineet, sir. One simple, very simple question, sir. Do all males should do a PSA as a diagnostic marker or not? And secondly, at what age we should get our PSA done sometimes, even if we don't have any symptoms?
Excellent question, because this has been a question that has been studied worldwide. Is PSA a useful screening marker or not? And the answer has not been found. So there's a lot of controversy, but it is sensible to do a PSA test once you cross 50 years of age. If you are having a positive family history, which means either in the direct, which means father, grandfather or paternal uncle has a history of CA prostate, then it's recommended that you do it after 40 years of age. Having said that, it is a lead time of 5 years before you find any symptoms of CA prostate. So I would, despite whatever the studies are available, I would strongly recommend that we should start doing a PSA once in 5 years if it is normal, after 50 years of age.
Dr. Gupta has a question.
So, thank you very much, Dr. Vineet and Abhishek was stressing on the skills rather than the procedure and the best. So, quick question to Dr. Abhishek. What are the arthroscopy packages costing in your hospital?
Sorry?
What are the arthroscopy packages costing in your hospital?
I cannot know a surgery which you are doing. And can be very variable. Like a diagnostic arthroscopy, in which you are not doing anything therapeutic, we are just trying to find out the cause.
Yeah.
It costs from 30 to 40,000. To a multi-ligament reconstruction. Suppose there is a patient who has multi-ligament injury, ACL, meniscus and MCL, which is very common. So that can go up to 4 to 5 lakhs. So it depends on what procedure you are doing. And recently I am now you have asked this question. Let me put across a very interesting fact. Nowadays, some bio-implants are being made, and very soon, I'm sure, within 3 to 6 months, they will become a fad, they will become very popular. And I was myself shocked to know, these are just augments when you are doing ACL, or when you are doing rotator cuff repair. And 2 or 3 companies are making it, and just these augments, like you will be using patient's grafts, and if you want to make this more strong, then you will be using these bio-augments. Right. And one augment for ACL is around 6 lakh rupees. So that will make the cost of surgery around 8 to 9 lakhs. Yeah. And this for rotator cuff approximately 8 lakh rupees, just the cost of this augment. Yeah. I don't know how popular it will be, but probably in insurance patients.
So that's obviously an option.
Yes.
So, and lastly, with the bilateral TKR, with the present generation implants that you have, how much of sports or what kind of sports can a person indulge in?
So ideally speaking, any high impact sports which involves running, jumping, jogging, like playing badminton or lawn tennis, that is not allowed. Only golf or swimming or cycling or treadmill at a low speed, up to 5, low intensity, without incline. But I have seen patients in West, like in US and Europe, I have seen people playing lawn tennis after TKR, because they are not scared of revision surgeries. If they say that let them enjoy their life, if things come to that stage, they'll get it revised, they'll get changed.
So then in that, what is the span between the first and the revision surgery on an average?
So approximately 20 years, 15 to 20 years, 20 years I would say, plus minus 1 2 years. Yes.
Dr. Vipul Mohan, our young dynamic cardiologist, MD Medicine, Diploma in Cardiology, he runs a very beautiful diagnostic center called the Capital Health Center in Hostas. He has a question.
Good evening, Dr. Vineet. Thank you for the informative talk. I just have one final question. What is your take on relatively young males coming up with symptoms of frequency and hesitancy? It's not particularly nocturnal, but when you do a basic ultrasound, there is some amount of increase in the prostate size. Not much significance in PVRU, but then there's a significant number that is growing of these patients. What is your take on this?
So we are aware that you can have irritative symptoms of bladder, especially both women and men in the young age, and these may not particularly be associated with obstructive symptoms. These are irritative symptoms, and it's fairly common. So we could have environmental factors, inflammation, infection, and we need to rule out all these things in these men. So essentially to know what the bladder capacity, so voiding diary and things like these become important these days. Whether the bladder capacity in a awake state versus the bladder capacity in an anesthetized state is different, so that we know whether this is functional bladder capacity versus total bladder capacity. Certain things that will help us identify whether there is a totally neurogenic phenomenon to this or there is a cytogenic phenomenon also here.
Dr. Biplab has a question.
Thanks, Dr. Vineet and Dr. Abhishek for giving nice talks. There is one small question. Is there any dramatic difference in between a laparoscopic prostatectomy and robotic prostatectomy? What's the difference?
So
they are highlighting the robotic prostatectomy so much. What's the difference?
So I tell you, if it was the same surgeon, the degree of freedom of instruments in a robotic surgery scores over laparoscopic surgery. Which is why I say it is the user behind the instrument. You have 7 degrees of freedom behind a robotic procedure, and you cannot do that with a laparoscopic procedure. You have better instruments now, you have those that angle, you have those that move around, but you don't have the 7 degrees of freedom that you would get like you would get in a wrist with a laparoscope as you would get with a robotic instrument. And that's the difference between the two procedures, that it allows you movement in all planes which a laparoscope would not allow. But then this is particular to a single user, and that's a very important point. Now, I've had some single users who have phenomenal experience in both excellent laparoscopic surgeons and brilliant robotic surgeons. In their hands, the robotic surgery would give them more benefit than the laparoscope, but that's particularly in those hands only, and otherwise you will not find that difference.
Over to the two masters, Dr. Tulsi sir and Dr. Malhotra. 3 minutes for Dr. Tulsi sir, 2 minutes for Dr. Malhotra.
चलो एक बार फिर से अजनबी बन जाए हम दोनों। चलो एक बार न मैं तुमसे कोई उम्मीद रखूं, दिल नवाज़ी की न तुम मेरी तरफ देखो, गलत अंदाज नजरों मेरे दिल की धड़कन लड़खड़ाए मेरी बातों में न जाहिर हो तुम्हारी हर कदम का आज नजरों से। चलो फिर से अजनबी बन जाए हम दोनों। चलो एक बार और
So let me begin by asking, he said 3 minutes, give me 13 minutes. So, to Dr. Vineet, what a nice talk, sir. So one of the most common malignancies in the male is 11% the Americans will have once in their lifetime. What about Indians?
It's a common malignancy after oral malignancy, pulmonary malignancy is the third commonest malignancy.
Again the same thing.
So in Indian men, unfortunately, because we oral tobacco commonly, oral malignancies and pulmonary malignancies are still commoner than prostate malignancies.
Dr. Vipendra.
So, Dr. Vipin, can you tell us how can we, prevent carcinoma prostate?
No, prostate malignancy is not a preventable malignancy, though there is a higher incidence noted between fatty diet and cancer prostate, but not too many other links between cancer prostate and other.
Let me say, as you rightly said, lifestyle modifications and fat diet probably is to some extent probably in CA prostate. But what about the 5 ARIs, the alpha reductase inhibitors? The SELECT trial also talked about 35,000 patients, talked about whether micro or macronutrients like selenium, vitamin E can reduce. They said no, it's absolutely no role. But what about the 2 landmark trials about the PET and the reduced trial? PET was on finasteride and reduced was on butostride. They said, let me complete, sir, they said probably they can reduce the CF prostate but also at a higher grade of CF prostate. But as compared to placebo, neither of these today are recommended for prevention of CF prostate.
So if you look at the outcomes of reduced, initially they thought that it would reduce the incidence of CA prostate, but what they found was that it didn't actually reduce the incidence of CA prostate. And in fact, now the belief is that identification only of aggressive forms of prostate becomes more apparent, but there's no reduction in the incidence of prostate whether you give finasteride or butostride in these patients. So it's not recommended anymore.
It's not recommended anymore, even though the survival is a pathetic 30%. So when you're talking about the METs, it's the axial skeleton followed by the lungs and the liver, which are emphasized here. But have you seen any unusual METs of CA prostate? So I'm going to refer to one case, that's why I'm asking you.
So my favorite site that I talk about is the penis. And you've seen about priapismic episodes after cancer prostate. So that's one of the sites that you may get. You may get lymphadenopathy also. So you've talked about axial, which means bony, and you've talked about lungs and liver. But the other thing is lymph nodes. And you do get lymph node metastasis also. But I will talk about something even rarer, which means priapism. Penile secondary to CA prostate and getting priapismic episodes. We've seen that also.
Let me talk about a rare case. A 61-year-old male. He had multiple METs to the liver and also the rectum, which is very rare. Even though the rectum and the prostate are very close by, it's normally prevented by aphasia, Dr. Poddar. Which fascia is that?
Absolutely right.
Yeah. That prevents the spread, but this patient had a spread to the rectum. See, and his PSA levels astonishingly were absolutely normal.
No, it's not astonishing. Now understand this. No.
So you can have a PSA normal with a CF METs.
Especially with the METs. Understand this.
Yes.
That you have anaplastic CA. The ones which the higher grade lesion and the less differentiated, the least differentiated ones will be so undifferentiated that the PSA levels will be really low or even normal in such cases. We sometimes get PSA which is is normal. So it's not unusual. When you get metastatic lesions, don't be surprised by seeing PSA which is low.
Okay, wonderful. So, have you seen this case ever?
I've actually seen something worse. I've seen something which shows a metastasis in the sigmoid, and that's extremely rare. You may still get it in the anal canal and the rectum, but you rarely get something in the sigmoid. And recently I've seen something with the secondary in the sigmoid, and that is extremely rare.
Finally, to Dr. Abhishek, great doctor. So, what about Iona as compared to, the standard arthroscopy that you do? Iona, sir. Iona is the in-office needle arthroscopy, which doesn't really need, anesthesia.
Nobody does it.
Nobody does? I believe it's an emerging modality today. Because you don't need regional anesthesia or a GA.
Dr. Tulsi sir, next CME.
In-office arthroscopy is called. It is being done in US, and that is still in a nascent stage. Not very popular, not very proven. In India, nobody does it.
Thank you, sir.
Next CME.
Thank you, sir. Next CME with you.
Dr. Kalda sir.
जब ट्विंस होते हैं, एक ट्विंस बड़ा हो जाता है, दूसरे छोटा होना पड़ता है, तो मैं छोटा ट्विंस ऐसा। I just wanted to from तो मेरे यार क्या बोलूं यार, विनीत की बात कर रहा हूँ सर। ED is an effect or cause of BPH.
Sir, ED is independent but associated and commonly associated with loops because of BPH. Which means when you have lower urinary tract symptoms because of any reason, you will have affection of your erectile function, and BPH is one of the etiologies which can cause it.
मुझे क्लियर ये कर लो, एक तरफ से तो कहते हैं कि 21 ejaculations per month, as it says, 21 ejaculations per month keeps your prostate health healthy. This is against ED. अगर आपको ED पहले हो गया तो क्या BPH हो जाएगा, और BPH हो गया तो क्या आपको ED हो जाएगा? क्या पहले होगा, क्या बाद में होगा? Just wanted to know from you.
Chicken and egg वाली story है sir.
So दूसरा वही एक ही बात है.
So the last question.
Sir, my last question is pellet therapy for radiations in the prostate cancer. How commonly are you using it?
Penile therapy.
Yeah.
So for radiation for prostate cancer, right now what we are doing is focus therapy, which means that you will have either therapy which is brachytherapy or focused as we use in these new accelerators that we use.
Ablation.
No, accelerators that we use. Linear accelerators. We use focused therapy with them. Again, understand that irrespective of the therapy you will use, you will have severe symptoms not immediately. Radiation leads to late symptoms. So 12 to 18 months later, you may have severe radiation proctitis or cystitis. And unfortunately, we get a lot of these men. They come with either hematuria, they come with severe tenesmus, rectal tenesmus, and they've had radiation therapy 1 year ago, so they're not even able to relate it to their radiation therapy which they had that long back. So it's important to identify this.
Sir, after 3 months we will have new simulation.
Dr. Abhishek, one last question to you. Before we wind up this, and I'll give it to two moderators. Actually, I got Dr. Vipender sir here. He's a surgeon. I wanted to ask you, is there a possibility of dealing with osteoarthritis in the knee, especially the monoarticular or monocompartmental type, with arthroscopy?
So actually, what you're asking is a very interesting topic. We can delve in great detail, but I'll just try to, very few limited cases of osteoarthritis can be dealt with arthroscopically. I'll tell you those, you yourself showed me the answer. It should be monoarticular, it should be localized, it should be a focal defect. Suppose the medial compartment है, वहाँ एक specific छोटे से एरिया में कार्टिलेज लॉस हो रखा है, बाकी जॉइंट मोरलेस मेंटेन्ड है, तो उसमें आप कार्टिलेज ग्राफ्ट या ओट्स या और भी कई सारे कुछ वो कर सकते हो और पेशेंट को फायदा होता है। बट फॉर अ ग्लोबल ऑस्टियोआर्थराइटिस आर्थ्रोस्कोपी इज नेवर एन ऑप्शन।
थैंक यू वेरी मच।
एक पॉइंट में मेक कर रहा हूँ, you know, we work and we are all end of the day private practitioners, we look at practice, but if you are interested in research, we are both extremely academically oriented also. I am now conducting a study on gut microflora and its effect on fertility, sexual function, aging and all these factors, and we are attached with a lot of international centers that are doing higher study, NGS, next generation gene sequencing and those methods into this. So if you really have interest in advanced research, we are the place, because we've not spoken about this, but we are into very advanced research, multi-center with a lot of places into trials. I'm looking at a lot of gut microflora, so there are different gut, and it's been identified. Now there's a lot of interest in how gut microflora may be involved in every process of cell aging and affect every cell process. And we are doing work on that. So if you have interest in that and you want to know more about that, you can reach out to us, because we are also very research oriented.
So we have two surgeons here, apart from two surgeons there, and some surgeons may be in the audience.
Here and there.
Here and there, yes. I would like Dr. Vipendra Sabharwal's comment on this CME and his take-home message for us.
Thank you, sir. As you all know, I am first thanks to Dr. Sushil Chauhan sir and Dr. Tulsi, Dr. Kala. I mean, it's a privilege. मैं हर बार की तरह दो लाइनों, चाहे मेरा पैशन सर्जरी है, मैं ये कहूँगा कि ना चांद की है चाहत, ना चांद की है चाहत, ना तारों की है ख्वाहिश, साथ मिले आपका बस इतनी सी है फरमाइश. So as a laparoscopic surgeon, I mean, I'm a faculty with Johnson, Stoll, and so many places, and I keep on teaching surgery, and it was enlightening. I mean, big round of applause for Dr. Vineet and Dr. Abhishek. I mean, सर्जरी में जो पहला मैं अपने स्टूडेंट को ये कहता हूँ कि सर्जरी में फर्स्ट वर्ड ही सर्ज है. It's all about adrenaline. It's all about surgery. It's all about what next. आज मैंने क्या what next? I think it was amazing the way they depicted the whole thing and the way they are trying to do new things. I think it's all about innovation. So it's amazing. So my take-home message is that keep on learning and keep on applying. It's not only about learning. And the present thing is how you unlearn, learn, and then relearn. You know, I was a general surgeon when I was in surgery. Then I started my laparoscopy. And the point is, what innovations can you make? So we learned so many things today, and I think it's amazing. And thank you so much, sir.